Good morning, dear students. I hope you hear me well. Today our topic is the introduction to splunkenology and functional anatomy of digestive tract. Here you can see the items for discussion. Later on, you will rewrite that to your copybooks. First of all, you need to understand what is splunkenology. It's a field of science studying viscera, means the internal organs. So all the organs are divided into tubal and parenchymatous ones. Tubal, these are all organs that are hollow inside, and parenchymatous are dense or fleshy. All of them, they have similar structure. Tubal organs, they have similar structure, like their walls are made up of tuniques, external, middle and internal. Even the dilated tubal organs or expanded, like stomach or urinary bladder, anyway they are tubal organs, so their structure is the same. The innermost tunique of the tubal organs is mostly called tunica mucosa or mucous tunique. The middle layer is mostly represented by smooth muscular lining or tunica muscularis in Latin, and the outer one is serous coating or tunique or adventitia. I should mention that those organs who are stretching much because they filled in with something like stomach or like urinary bladder, so if the organ is stretchable much, it should have some buffer lining between the mucous layer and the muscular layer, because their stretchability is to different extent. There should be some buffer in between, and this intermediate layer in between mucous and muscular is called tela submucosa or submucous layer. So you can remember that for exam, if the organ is stretchable much, it should have submucous layer for sure. Then we're coming up to the parenchymatous organs, or dense or fleshy organs. They are divided into stroma and parenchyma, means in their structure we can see stroma. So what is stroma? It's a framework, solid, hard framework made up of vessels, ducts that are inside the organ, and that gives the shaping of this organ, because all vessels and ducts, they are divided according to the number of the lobes, segments, lobules, and therefore their number will be corresponding to the number of division of the parenchymatous organ. The parenchyma is the histological tissue in between these vessels and ducts. So actually this is proper tissue of organ that is functionally unique and predisposes the function of this organ. On exam, you just have to remember this organ is tubal and parenchymatous, and based on this scheme, you can easily remember the structure of the organ. I should remind you that according to the classification, there are three types of body systems. They are labor systems, to them belong locomotor, that is bones, joints and muscles. Vital systems, we devote to that digestive, respiratory, urinary and genital. And integrational systems, to them nervous, immune and endocrine systems belong. Why are they divided like that? Just because of their function. Like we had exact plan of description for bones and joints and muscles, the same plan of description we need to follow while describing the viscera or internal organs. This plan is necessary just to have a logic sequence of what we are saying and for narrating the pictures that we can see. So we can describe X-ray films or MRI or CT scan films without forgetting anything. So while describing, we have to mention the name of the organ in Latin and in Greek. Mostly the names of the diseases are originating from Greek roots. That's why we are learning Greek terms as well. Then you are to mention the functions of the organ. And there is not a single organ in the body that has the one function. All of them, they have several functions. The next, you should say the source of embryonic development. That is necessary to understand how the anomalies of development occur and which factors can cause them, and how they relate to each other. What is the connection between the development of different lesions? The next item is to mention topography. What is topography? That is the location in the body, and it includes holotopy, skeletotopy, and syntopy. Holotopy means you should say what cavity this organ is located in. You should know that the cavities are like cranial cavity or oral cavity, neck region, not cavity but region, then thoracic cavity, abdominal cavity, and pelvic area, pelvic cavity. The next thing you should mention is coverage by serous coating. Here I wrote by peritoneum, but that is related only for abdominal organs. We have serous coating for other organs also. And you should say the relation to the topographic body regions. I will describe later what does it mean. The next thing to be described in topography is skeletotopy. It means relation to the skeletal landmarks. Then syntopy, that is relation to the neighboring organs. Why do we need that? Skeletotopy and syntopy. When you see two patients, one is short and one is high or tall, their organs are on the different level related to your eyes, but related to their skeleton, they are on the same level. So independently of the size of the patient, the organs are related the same in normal conditions to their skeleton. That's why skeletotopy helps us to identify the normal bodies of the organ. And why do you need syntopy or relation to the neighboring organs? The point is that in many diseases, the pains from the neighboring organs can simulate the lesion of the organ we are studying or we are examining. For example, some students can think they have the pain in stomach, but in reality, if we'll examine them, we can reveal that probably not stomach, but pancreas, which is partially below and partially behind stomach, is damaged. The exact diagnosis can help us to prescribe the proper treatment, and let's say the treatment for gastritis and for pancreatitis is quite opposite. Therefore, if you will not put the correct diagnosis, if you will not make it the correct diagnosis, your treatment may even do the harm. The other example about the necessity of syntopy learning, there is the so-called abdominal form of myocardial infarction. When the patient complains to severe pains in stomach, but in reality he has myocardial infarction or with severe lesion of heart structure. Therefore, syncope is necessary. The next necessary thing to be described in the plan of description for viscera is gross structure. Gross means what we can see with the bare eye, like anatomical structure, surfaces, borders, grooves, large lobes, and etc. For example, ligaments. The next, we're describing histological structure, means how tissue is arranged, what does it do, and how we can see that in the light microscope. The next, anomalies of development. This item is closely connected to point number 3, that is embryonic development. Majority of anomalies, inborn anomalies, they're associated with some impact factor or exposure in the embryonic development. The next, methods of investigation. We mention here just anatomical methods. Anatomical means visual. And you know which visual methods can we use here. We can use just dissection only post-mortem, but pre-life or alive methods, we use ultrasound, CT scan, MRI, like this, angiography. These all are visual methods. And the last point, blood supply, venous and lymphatic drainage and innervation, we'll study a bit later when you will learn the vessels and nerves. Talking about the topography, we should know what is topographical lines. So to identify the exact position of the organs for abdominal cavity, we use topographical lines. Here you can see the vertical line which is passed through the 10th ribs, and that line is called linea bicostarum or bicostar line. The other one, vertical line, is called linea bispinarum in Latin, and it connects the spina iliaca anterior superior. And these two vertical line divides the abdominal region to epigastrium, which is above, mesogastrium, the middle floor, and hypogastrium, which is below the lower line. So these three floors, epigastrium, mesogastrium, and hypogastrium. For thoracic cavity, we didn't have these vertical lines. Instead, we have the ribs. These ribs will serve the X lines or X axis for the coordinates of the organ. The vertical additional lines are necessary to give the exact location of the region. These vertical lines, they pass along the lateral borders of rectus abdominis muscles of the abdomen, and these vertical lines will divide each floor into 3 more regions, having 9 in total. So the epigastric region will be divided by these lines to right hypochondriac region, left hypochondriac region, and epigastric proper. Hypochondriac means behind the cartilage, behind the ribs. The next floor, mesogastrium, will be divided into right lumbar region, left lumbar region, sometimes they are called right and left abdominal regions. And what is in the middle is called umbilical region. The hypogastrium region is divided into right inguinal, left inguinal, and pubic region. In total, that will be composing the hypogastric region. Now, if we place the projection of organs to this area, You can identify easily where the borders should be thanks to these abdominopelvic regions. So here is the division of the abdominal area into regions, and you can just make photo and then rewrite to your copybooks. For the thoracic region, we do not need the horizontal lines. I said instead ribs are serving for that, but the vertical lines you know already from the first semester. They are anterior medial line, which is called linea mediana anterior. I will come back and show that. Anterior medial line, then sternal lines, parasternal lines, right and left, mid-clavicle lines, then three lines are passing through the axillary fossa. One anteriorly is called anterior axillary line, then medial axillary line and posterior axillary as well. And from the back, through the lower angle of scapula, there comes the scapular line. Then corresponding to the transverse processes, there will be paravertebral line and the posterior medial line as well. Now we are coming closer to digestive system. In Latin that sounds as systema digestorium, digestive system. And the functions of digestive system are as follows. First of all, providing the processed nutrients to the body tissues, because the tissues cannot consume the unprocessed things. The next, eliminating the undigested wastes, and that is also very important. The next, endocrine function, because most of the glands, they have specific endocrine glands, they have specific influence to different our body functions, and some of them are along the digestive tract. The next, participation in maintenance of the blood pH. And the last one, participation in supporting of osmotic and oncotic pressure of the blood. These are major functions. Of course, many other small functions exist, and you will know that further while you will be studying the physiology, pathology, and etc. Now to embryonic development of the digestive system. During embryonic development in embryo, there forms the primary tube from the endoderm. Here it is seen better, primary tube from the endoderm, and it's closed from both ends, so it's blind-ended from both sides. Then from the both sides, both ends of the embryo, from the oral part and from the caudal part, there grows the oral and anal pouches towards this canal, and they are developing from ectoderm. So we can say that both endoderm and ectoderm participates in formation of the digestive tube. Oral pouch and anal pouch are growing towards this blind-ended tube to join with them and to form the entire alimentary tract, which will be open to oral side and to anal side. Then this tube will be divided into three parts: foregut, that is front portion, midgut, that is in the middle, and hindgut, which is at the end. Foregut on its ventral side gives rise to a small tube which will be developing to future respiratory system, and this small tube will be connecting the future respiratory system with the digestive canal. This tube should obliterate or fuse just before the birth. If it will not be fused, the newborn will have serious pathology. This will be called tracheoesophageal fistula, and that will cause suffocation of the newborn by the milk while breastfeeding. The midgut gives rise to large digestive glands like liver and pancreas, and also gall bladder will be developing from this side. The hindgut initially will be connected to the urogenital sinus and have the image of cloaca. This is primitive structure that is common pouch for urine and feces, but then it will be separated. If not, of course, the anomaly will be caused by that. So here I'm showing you the connection of embryonic development and anomalies of development. So, and here are the organs that develop from different portions of the digestive tube, and actually digestive system is divided into digestive tube and digestive glands. The sequence of the organs is the following. First of all, that's oral cavity, then pharynx, then esophagus, then stomach, small intestine, large intestine, and then anal canal. In turn, small intestine will be represented by duodenum, jejunum, and ilium. Large intestine will be represented by blind intestine called cecum, ascending colon, transverse colon, descending colon, and sigmoid colon. The anal canal or rectum will be the last portion of the digestive canal, and all the glands belonging to digestive system will be represented by large glands and small glands. Large glands, in oral cavity there are 3 pairs of salivary glands, and in abdominal cavity they are liver and pancreas. This one. Small salivary glands, they are scattered all along the digestive tube. So here is the scheme, what I have said about the division to the tube and to glands, and the representation of the glands, like division into large glands and small glands. Make photo of this slide and then you will write that to your copybooks. And we'll start from the upper portion of the digestive system, like oral cavity. Oral cavity starts from the entrance to it. In Latin, that is oral slit, is called rima oris. That is the oral slit, rima oris. Lips are surrounding this oral slit, and the upper lip and the lower lip are connected by labial commissures in the angle, having the groove that is called philtrum on the top, and that is having the small upper lip tubercle. Behind the lips there are the teeth. In between the lips and the cheeks from one side anteriorly, and teeth and gums posteriorly, this cavity is called vestibulum oris, or oral vestibule. So in general we can say that oral cavity is divided into oral vestibule and oral cavity proper. Oral vestibule is front to teeth, Oral cavity proper is behind the teeth. Inside the oral cavity, I will turn back to show you again. The roof of the oral cavity is the same that the floor of the nasal cavity. So the bones are the same. As you remember from the first semester, the roof is represented by the palatine process of maxilla, small portion of it, and horizontal plate of the palatine bone. There is hard palate and exactly the bony part of palate. But also we have the fleshy part that is called soft palate. And soft palate will have muscles creating the fleshy part, and these muscles help to elevate the palate and to form bolus or food portion, and prevents the snoring. So if there will be the paralysis of this muscle, or if the nerves will be damaged that supply these muscles, you will know it by night snoring. So muscles of soft palate include musculus levator veli palatini, that elevates, musculus tensor veli palatini, that tenses, then musculus uvule, that is small, like process of small fleshy portion hanging in the middle, musculus uvule, and two arcs, palatoglossal and palatopharyngeal. I will show them on the slides further. They also have muscles inside. On the floor of the oral cavity, you will see the tongue and muscles below the tongue. The tongue, in Latin that sounds lingua, and in Greek glossum. The tongue is a fleshy organ, no bone inside, fleshy organ that has superior portion, superior surface, and inferior surface. Also it has the apex or the tip and the root, radix linguae. The inside the tongue has muscles, 4 of them extrinsic and 4 intrinsic. So I can move the tongue, you all can move the tongue by your will, but some muscles anyway, they are smooth muscles. So they are under the influence of autonomic nervous system. The superior surface of tongue is covered with the taste buds called papilla, and we have 6 types of taste buds here. We have papilla vallata or circumvallate papilla. Here are they're large and form like turned V-shaped structure on the root of tongue. Then the tiny ones, they are called papillae filiformis. They're all along, very small, almost invisible. Filiform papilla. Then leaf-like, they're called papilla foliata. These are on the sides, foliate papilla. Then fungiform papilla, they are visible, fungiform. Also conic papilla exists, some of them, conic. And the last, lentiform, so 6 types, easy to remember, 3 F's, filiform, fungiform, foliate, similar to sound vallate or circumvallate. And the last 2 are conic and circumvallate. Few years ago, we studied the taste perception by tongue using the tongue map. We said that the tip was percepting mostly the salty food, the sides mostly the sour food, the root mostly the bitter food, and etc. So we use the mapping of taste perception by tongue. Nowadays, this theory of tongue mapping is not quite accepted by all the scientists, and they say that the taste buds, they are all around the tongue, so we do not use mapping anymore. At the root of the tongue, this one, you can see the lymphoid tissue that accomplishes the immune function, and sometimes you can see the coating of the tongue because of this lymphoid tissue function. And this is called lingual tonsil. So the tonsils may be different, they may have different appearance. So if it is a flat tissue that is not extending from the surface of tongue, anyway, that is its tonsil. This one is unpaired lingual tonsil. Behind it, there is the fold called glossoepiglottic fold. Here you can see it. And it's medial glossoepiglottic fold, and there are two lateral glossoepiglottic folds. They're called plicas. In between, there are small forces called vallecula, and these are called vallecula glossoepiglottica or epiglottic fossas. Sometimes they serve the place where the foreign objects may stuck in the toddlers that are starting to crawl and that are collecting some pieces of cotton or pieces of paper, some small strange things they have found on the floor, and they may stuck here in these small dimples. As the result, the children, the kids will manifest such symptoms like fever, diarrhea, vomiting, but nothing will be found during investigation. Just the very attentive examining of the oral cavity and of the tongue will show you that something is in, and you can remove it just with the gauze wrapped around your finger. Wrap it, and that's it. That's all the treatment. The fever will drop down and the symptoms will disappear, and the kid will eat the food again and will be happy. Behind all that, you will see the epiglottis, which belongs already to the respiratory system, and this epiglottis, it acts during our swallowing of food. It acts as the door to close the entrance to larynx, because the continuation of the oral pharynx, that is oropharynx, continuation of to esophagus, is behind. So why your mothers said to you not to talk when you are eating? Because not to have suffocation. So when you swallow, this epiglottis close the entrance to larynx, which is front, to let your food bolus move to esophagus, which is behind. This was anterior surface, or superior surface of the tongue. And this is the picture of the enlarged taste buds that I was talking about. On the inferior surface of tongue, you can see the median fold, this one, which is called frenulum. Frenulum linguae, this one. On both sides of this frenulum and on the bottom, there are two small papilla. They are called caruncula sublingualis, These are exits of the ducts, sublingual and submandibular salivary glands. They both open here below the tongue. Probably you remember when you are visiting dentists, dentists usually put a piece of cotton below the tongue to prevent excess salivation to work easy. And also on this picture you can see two more frenulums which are not belonging to oral proper cavity, but they belong to vestibule, oral vestibule. These two are called frenulum labii superioris or superior lip frenulum and inferior lip frenulum. They are connecting the lip and the gum. The clinical importance of these two frenulums is if they are attached very low or if they are shorter than normal, that may cause the appearance of a slit between the central incisors. So a space will be between central incisors. To prevent that, if you notice that in the, let's say, child of 6-7 years old, you can just make a cut of the small cut of the frenulum, and that will help the teeth to grow normally. In the kids before 5-year-old, that is a normal condition because their teeth are just to change from the milky to permanent. The next thing we are to discuss is the teeth. So as I mentioned before, the teeth can be milky or temporary and adult or permanent. The normal time of eruption of milky teeth is around 6 months, and usually the incisors are erupting the first. There are only 20 milky teeth that should erupt before 2 years old. So the 2-year-old child should have 20 milky teeth. And the child will have that teeth up to 5-7 years old, and then the adult or permanent teeth will start eruption. And the adults compared to kids should have 32 teeth. Here you can see that person, that's a kid. The buds for permanent teeth are inside the jars, maxilla and mandible, and milky teeth are erupted. The structure. The tooth has the crown that we can see and the root that is inside the gum and alveole. Alveole, that is the belonging to the jaw. The crown is covered by enamel, very hard tissue, below which is dentin. Inside, the tooth has the cavity filled in with connective tissue with the small arteriole or capillaries coming into to provide the nutrients for this tooth. And arteries, veins and nerves. So despite tooth is a very hard tissue, anyway it's alive. That's why it should be nourished. The root is covered by cementum around the pulp cavity, and dentine is also covering that pulp. The pulp has the continuation called the root canal, which ends with apical foramen and exits to bone. That serves the canal for the vessels. In between the crown and the root, there is the small portion called neck, and it's a boundary, it serves a boundary between root and crown. Now about the names of the teeth. Each tooth has the name. The types of the names are like that. The cutting teeth are called incisors. The tearing teeth are called canine teeth. Then premolars and molars. So once again, incisors, canines, premolars and molars. If we'll write down the adult teeth formula, we can name or numerate each tooth by the figure, and figure number 1 will mean incisor, and figure number, let's say, 3 canine, 4 5s will be premolars, and 3 more will be molars. Along with that, the clinical formula exists, where we use 2 digital type of enumerating each tooth. And this starts from the upper left quarter of jaws, then goes down to left portion of mandible teeth, then to right portion of mandible teeth, and then again returns back to left maxillar teeth. So clockwise numerating. In kids, we also use teeth formula, 1 digital numeration and 2 digital or clinical numeration, but the numbers are different. Firstly, that is associated with the fact that the kids lack premolars. There are no premolars. So the kids' teeth formula is, once again, the kids' formula is 2 1 0 2, which is 2 incisors, 1 canine, 0 premolars, and 3 molars, compared to adult formula where 2 1 2 3, 2 incisors, 1 canine, 2 premolars, and 3 molars. About salivary glands, I will talk a bit later when I will show you the glands. For now, I will mention just all of them are large salivary glands are in oral cavity, and the sublingual and submandibular has the exit to sublingual caruncle, and the parotid gland, it has the duct opening to the level of the upper second molar tooth in the oral vestibule. The next portion of the digestive system I'm going to talk about is pharynx. Pharynx is behind the oral proper cavity and is divided, is separated by a vertical boundary. It's vertical, so it's not having beginning. Vertical boundary, which is called isthmus phalanges. Isthmus phalanges. And the pharynx is divided into 3 portions: nasopharynx, oropharynx, and laryngopharynx. The vertical boundary between nasopharynx and oropharynx is the horizontal line that is passing through the hard palate. The boundary between oral pharynx and laryngopharynx is epiglottis, that is the cartilage belonging to a respiratory system and closing the entrance to larynx when we swallow. These are the parts of pharynx seen better. And nasopharynx, its peculiarity is that it's connected to the nasal cavity by means of choana. Choanas, these are exits from the nasal cavity to nasopharynx. Sometimes when you suffocate, when you are swimming, you can feel suffocation when the water can come from nose to nasopharynx. That's very unpleasant feeling, but that shows the connection of these structures. With the oral pharynx, with the oral cavity, oropharynx is communicating by means of isthmus faucis, or Fuchs isthmus. The lining of pharynx is the same with all tubal organs because it's a funnel-like dilated tube, so it should have mucosa, submucosa, muscular layer, and adventitious. So that's therefore the mucous layer. It's very interesting because in pharynx it has the ciliary epithelium, which is very sensitive and cause sneezing, coughing, suffocation sometimes. So it provides us reflexes to any unpleasant situations. Also, it's full of lymphoid tissue and lymphoid structures. Here in this picture, I will show you the location of the pharyngeal tonsil, herein, pharyngeal tonsil. That is the flat, it's not grapes-like, no, it's a flat tissue, lymphoid tissue, which is called pharyngeal tonsil. It accomplishes immune system. In case when it is enlarged and extends from the flat surface of the pharynx, it's called adenoids. And the kids who have adenoids, they can't breathe through their nose. Their mouth is always open. So this is one tonsil and it's unpaired. Then lingual tonsil, herein I showed you at the root of the tongue. And two more pairs of tonsils exist. They're palatine tonsils and tubal tonsils. Palatine tonsils, Palatine tonsils are located between two arcs, palatoglossal and palatopharyngeal. Tubal tonsil, also paired, they're located at the orifice of Eustachian tube. Eustachian tube is a connection between your pharynx and middle ear, because middle ear inside having air. So all these 6 tonsils, 2 paired, tubal and palatine, and 2 unpaired, pharyngeal and lingual, they altogether form the lymphoepithelial ring of Pyrgo-Valdea. So this is the immune barrier on the way of infection towards our body. If this immune barrier works well normally, means the infection will not get down. Instead, we'll have inflammation in this area, and there it will stop. It will not go further. The next layer, below the submucosal is muscular layer, and it's represented by muscles like dilators and constrictors. Dilators are stylopharyngeal and palatopharyngeal, and constrictors superior, medial, and inferior, three constrictors. Altogether, dilators and constrictors, they help us to form the peristaltic wave. When we're swallowing, the first peristaltic wave starts, and then in the esophagus we'll see the contraction of longitudinal layer of muscular tunic and circular layer, and that will create peristaltic wave. The next portion of digestive tract is esophagus. So it starts from the C6 level, means from the 6th cervical vertebra, C6, C7, like that. It passes down from the neck region to the thoracic cavity, and it also has the small abdominal part. So for esophagus we can say there are three parts: cervical, thoracic, and abdominal. All along it has constrictions because some organs are neighboring esophagus and causing the appearance of these constrictions. So there are cervical constriction, then aortic, bronchial constriction, diaphragmatic constriction or phrenic constriction, and cardiac, because the initialmost part of the stomach is called cardia. The walls are the same like all tubal organs, so muscular layer, then first mucosal layer, then submucous, then muscular, and then adventitia. Here it's shown that when circular muscles constrict, then longitudinal muscles constrict, the peristaltic wave forces the bolus to move towards the stomach. Actually, the food is not absorbed in esophagus, and that is how the wall of esophagus seen in the light microscope. The next portion, stomach. In Latin that sounds ventriculus, in Greek gaster. And stomach has it's a tubal organ because it's hollow inside, but it has quite irregular shape. It has the dome-like structure called fornix or fundus. Then it has cardiac part herein. It has the body, this one, and it has pyloric part. Also, we distinguish the lesser curvature of stomach and greater curvature. Every part of stomach has its own function. For example, fluids are mostly moving along the lesser curvature. The clinical importance is when the person, mostly often kids, are drinking by mistake any aggressive fluid like acid for example. Mostly the lesser curvature will be damaged. If the spicy food or if the poisoned food will appear in solid portion of it, the greater curvature will suffer more. So the greater curvature is for solid food. And the fundus herein, dome-like portion, is for accumulating the gas which you are swallowing when you are eating very fast. It accumulates here and then it goes out, sometimes with the sound. The innermost layer in the stomach is again called mucosa. Below it we have submucosal layer or tela. And the muscular layer is represented by three coatings, by three strates. These are circular, longitudinal, and oblique. So these are longitudinal and these are oblique because of irregular shape of stomach. You know from your experience that stomach is very stretchable organ, therefore oblique fibers are necessary as well as circular and longitudinal. So here is the natural sample of stomach. The internal relief or landscape of stomach looks like folding. So these folds also have villi, and the flat portions called squares. We call them area gastricae. So plica gastricae and area gastricae. And that is the groove along which the fluids usually move. The lowermost portion, that is called pyloric part, has antrum, pyloric canal, and pyloric sphincter. The medium inside the stomach is acidic, aggressive acidic, to help to split the proteins. And the denaturation of the proteins causes easier consumption. Muscularly, it's also the natural sample, and here it's represented well, the circular layer, the longitudinal, and herein oblique fibers. And again the picture, how does it look like? The mucosal layer has many gastric glands, and there are three types of these cells. The parietal cells, they produce hydrochloric acid, and intrinsic factor, which is called Castle factor, preventing the anemia, specific type of anemia. Then chief cells, which produce pepsinogen, and endocrine cells or G cells. They produce several hormones like gastrin and stimulates parietal and chief cells. The next, small intestine, a part of the stomach where mostly proteins will be denaturated and absorbed. The major function of small intestine is to process fats and fat-soluble substances. The major function. So mostly it will be busy with that. Stomach starts from the pyloric sphincter, small intestine starts from the pyloric sphincter of stomach, and has the name intestinum tenum, and is divided into three parts. They are duodenum, duodenum in Latin, jejunum, in Latin jejunum, and ilium, in Latin the same ilium. And these three parts, this is a natural sample, they all will be busy with the processing and absorption of fats and fat-soluble substances. Among very important fat-soluble substances, you should know 4 vitamins that are fat-soluble: A, D, E, K. Very important vitamins, and their deficiency causes serious problems in the body, right? So if they will be not absorbed in the small intestine, that will be the problem for the body. So not always, for example, the problems with the vision is because of the lesion of the eyes. Probably one of the reasons may be poor absorption of vitamin A in small intestine. The first part of small intestine, which is called duodenum, herein, starts from the pyloric sphincter, has 4 parts: superior part, descending part, horizontal part, and descending part. And it's located in between level L1, first lumbar vertebra. From L1 to L3, descending part. Along L3, and descending part from L3 ascends to L2 vertebra. So it's a horseshoe shape, as you can see, but in kids it's almost C shape, having no exact flexure, superior duodenal flexure and inferior duodenal flexure. The interesting thing is that to the descending part of the duodenum, to its medial posterior wall, opens the common duct from Gall Bladder, exactly from liver and then through Gall Bladder, and from pancreas. So both bile and pancreatic juice will appear in descending part of duodenum. And this bile is such an aggressive alkaline medium that it helps to split fats, fatty acids, fat-soluble substances. This structure is similar, so mucosal layer with villi, submucosal tela, muscular layer, and serous coating. And as you can see here, it's shown how it appears in the duodenum, these common fluids, alkaline fluids. And the next part after duodenum is jejunum. Jejunum is about 2.5 meters long compared to ilium, which is 3.5 meters long. And jejunum is mostly having the vertical folds, while ilium having horizontal folds. They both have villi for absorption of fats and fat-soluble substances. And for practical classes, you have to know at least 10 differences between jejunum and ilium. Firstly, the villi in jejunum, I will name just few of them. The villi in jejunum are longer and more dense, while in ilium they are shorter and more loose. Then in jejunum, the color is more pinkish, while the color of ilium is pink-grayish. Jejunum is shorter, while ilium is longer. In jejunum, the amount of fatty tissue in its mesentery is more. In ilium, it's less. The width of the wall, the thickness of the wall in jejunum is more, in ilium less. The elasticity of the wall, in jejunum the wall is more elastic, in ilium less elastic. The blood vessels in the mesentery is represented in jejunum by the arcades of 3 levels, in ileum of 2 levels. So the general regularity, we can summarize that in ileum everything is less or poorer. That will help you to remember. Ileum will finish with the sphincter that will close the entrance to the large intestine. This is the ileocecal valve that is in between cecum and ileum. Here again the villi structure of small intestine is shown. Because it absorbs fats, as I said before, inside it, a part of capillaries and venules, a part of that, it has the lymphatic capillary, which will absorb fat and fat-soluble substances. Now, large intestine. It's called in Latin intestinum crassum. Intestinum crassum. The function of large intestine is as follows: reabsorption of water and absorption of water, compaction of intestinal contents into feces, absorption of important water-soluble vitamins, because fat-soluble were consumed above, and storage of fecal material before defecation, so temporary storage. This is the image of large intestine. As you can see, it lacks villi, because water and water-soluble substances, they do not need villi to be consumed. It easily can pass through the wall, therefore no villi. Instead, it has the folds. These folds cause the bulges in between them. These bulges are called haustras. And these haustras are seen really like bulges. And one more difference of large intestine compared to the small one is that large intestine has no entire muscular layer. Instead, muscular layer is represented by 3 ribbons, which are called taenia. Ribbon, translation into Latin, taenia. And we have 3 taenias: taenia libera, taenia mesocolica, and taenia ommentalis. So these 3 taenias are nothing else but containing muscular tissue inside. From the outside, from the abdominal cavity, along these taenias, we can see the fatty protrusions or fatty like earrings that we called Appendices Epiploidsis. It's really like processes, fatty processes. So in Latin, Appendices Epiploidsis. And here you can see the ileocecal valve, which opens into the first portion of large intestine called cecum, typhlon in Greek. In this cecum, we can find the appendix, that is small process herein. The main function of it is to be the store of the intestinal bacteria necessary for feces formation, necessary for producing of vitamins. So this is a normal flora of intestine. Sometimes in case of the constipations, in case of inflammations, this process also can be inflamed, and in this case we call it appendicitis. Returning back to large intestine, the parts of it are cecum, translation of it is blind intestine, then ascending colon, transverse colon, descending, then sigmoid, resembling the Greek sigma letter, and then rectum. Here are the parts, you can make photo. And here you can see the length of the large intestine, but in reality it's different. It depends on the height of the person, it depends on the female or male, it depends on the diet. Quite different factors can influence. Sometimes this transverse part is very low and it also elongates the large intestine. The anal canal has different structure compared to large intestine and to small intestine because it's the last portion where the feces is formed, water is reabsorbed, and it has peculiarities. You remember that anal canal or rectum, it develops from the anal pouch, so not from the entoderm but from the ectoderm. Therefore, if it will not rupture into the primary intestinal tube, then the anal atresia or blind end will be found in a newborn. So, anal canal finishes with this external anal sphincter hearing. Also, much above, there is internal anal sphincter. Internal is involuntary, while external is voluntary, when you can keep before you find the toilet. The internal structure of anal canal also folding and colons inside. Because it develops from the different source, the blood supply of the rectum is also different. The superior portion of rectum will be supplied from the inferior mesenteric artery and will be drained to hepatic portal vein for filtering, for detoxification, and the middle and inferior portions of rectum will be supplied from the internal iliac artery and from the pudendal, which in turn belongs to internal pudendal artery, and they will be drained to internal iliac veins, means directly to the greater or systemic circulation. This knowledge we can use in clinic. Firstly, when there is no venous access to urgent intravenous injection, we can use anal canal for suppositoria, for rectal administration of some medicines. They will be absorbed directly to greater or systemic circulation, skipping the being filtered in liver. That also is used in newborns sometimes when the venous access is hard, or when there is no time but the newborn has seizures or cramps, or sometimes in adults when we do not want to overload the sick liver, for example in cirrhotic liver, or liver with cirrhosis, or hepatitis, when we do not want to load the liver. Now, digestive glands. As I said before, digestive glands are different and if we'll take in general what glands exist, we can classify them into exocrine, endocrine, and mixed. What is the difference between these three? Endocrine means they produce substance directly into blood. So the substance these glands produce appear directly in blood. Exocrine means they have some collective duct which exits, which opens into the lumen of some tubal organ. And mixed means the glands that have both parts. And in digestive tracts, like these, are liver and pancreas. Digestive glands, in turn, they can be classified into large and small. Large, I said, 3 salivary glands, like parotid, submandibular, and sublingual. And also large glands are liver and pancreas, which are developing from the midgut. Small gut, they are divided into oral. They are small glands producing saliva, and they're labial, buccal, palatine, molar, lingual, and small glands in gut, pharyngeal, esophageal, gastric, intestinal. Now, according to structure, all glands can be classified into simple and compound. Simple are alveolar or tubular. These are alveolar glands, and these are tubular glands, just according to their shape. That's it. Alveolar are sac shape, tubular are just like small tubule. And these are their branching. Branched alveolar and branched tubular. And compound glands are branched, as you see before. Now, according to produced substance, glands are divided into mucosal, serous, hormonal, and mixed, depending on the substance they produce. I think nothing to explain, it's evident. Now, according to the type of secretion, so what is happening to the gland, how they excrete? They're divided into merocrine, so while they produce something, they preserve their shape. Then epicrine, while they're producing something, they are destroyed partially. And holocrine, they are completely destroyed. Now you can learn the glands of digestive system without cramming, but instead you understand what you are learning. Acinus in gland means the small part which produces the substance. And its structure is acinar epithelium or myepithelial cell and basal membrane. And according to structure, they are divided into serous acini, mucous acini, and mixed acini. About the general outline, I said already, what are they doing and where are they scattered? Now we'll be talking in particular about large salivary glands. I said it includes parotid, submandibular, and sublingual. They are compound tubular acinar glands. So they are composed of acini and ducts. Parotid gland, it's located in the retromandibular fossa. Submandibular and sublingual, they are located in the oral floor, below the tongue. Parotid gland secretes 25% of saliva, but more it produces amylase and less mucose. It's compound alveolar in structure, and the ducts opens at the level of upper second molar tooth in the oral vestibule. And it's pure serous gland. In kids, the infection disease of parotid gland is called mumps. In adults who have no mumps, in majority, they can have tumor of parotid gland. This is how it looks like. Very serious condition. Submandibular and submandibular gland is a mixed. It's short intercalated duct and longer striated duct, and it secretes only 70% of saliva. All the remaining part is salivary amylase and more mucus. It's tubular alveolar duct, as you can see here, alveolar and small tubes. The opening is at the carunculus sublingualis on both sides of the frenulum linguae. Sublingual is opposite. It secretes only 5% of saliva, but mostly mucus. It's a mixed gland. The opening is at the same place with the submandibular, and there is the microscopic image of the sublingual gland. The next large gland is liver. The function of liver is the formation of bile non-stop 24 hours per day, formation of bile, accumulation of glycogen, antitoxic, means the main function of liver is, I would say, filtering and detoxification of blood. Detoxification from what we have eaten and what have been absorbed from the gut. In embryonic period, a liver also accomplishes hematopoietic function, so the blood cells are formed in the liver. That's why in embryonic period, liver occupies 2/3 of abdominal cavity, shifting all the neighboring organs to different sides. It shifts the neighboring kidney, right kidney, downwards. It shifts through diaphragm, through the right dome of diaphragm. It shifts all thoracic organs beat clockwise. That's why the right dome of the diaphragm is higher, the right lung is bigger than the heart. From its initial midline position shifts bit leftwards and appears as if invaded into left lung, and left lung becomes slimmer and descends bit downwards. So that's because of liver. The next, immune function, then barrier function. Majority of poisonous and hazardous agents, they remain in liver. Also, accumulation of fat-soluble vitamins A, D, E, K, and vitamin similar biologically active substances. Endocrine function, and it also serves a depot of essential amino acids. These are only 9 functions. Of course, there are really more, because liver is called biochemical laboratory of the body. The skeletotopy of liver is located from the approx 4/5 intercostal and will not extend the 10th rib along the right mid-clavicle line. But then, moving towards the left side, the left lobe of the liver is on the middle of the distance between the xiphoid process and the navel. You can find that here at the level of approx L1. Then, this was skeletotopy. In kids, a liver can be even below the 10th rib, and you can write in case history +4 centimeters below the 10th rib along the right mid-clavicle line. It's okay for kids. After 5, that is considered a pathology. That's skeletotopy. Now holotopy. Liver is located in the right abdominal region, in right hypochondriac, then epigastric proper regions, and even small portion may go even to left hypochondriac, but just in seldom times. Now syntopy of liver. Liver is such a fleshy and such a soft tissue that all the neighboring organs leave the impressions or depressions on its surface. We call them impressio in Latin. So knowing the impressions, you can know the liver syncope. You can know which organs are surrounding liver. And here I listed them all. And the names of impressions are impressio esophagealis, impressio gastrica, impressio colica, impressio duodenalis, impressio renalis. All of them are listed here. For gross anatomy of liver, you should also mention the ligaments of liver, which are divided into visceral and like duplications of the peritoneum. It's a very heavy organ and should be fixed reliably in abdominal cavity in its upper right portion. Therefore, ligaments are very necessary. Proper ligaments of liver, they are teres ligament, falciform, which divides the liver into two lobes, then coronarium, crown-like, which is above, then triangular dexter and sinistra, ligaments of liver. Visceral ligaments means they are the peritoneal folds that pass from liver to the neighboring organs. Exactly these form the visceral ligaments. They are called ligamentum hepatorenale, means its connection by peritoneal fold of liver and kidney. Ligamentum hepatoduodenale to duodenum, how it's fixed to duodenum, and hepatogastricum, how it's fixed to stomach. I will show. Here, number 7. This ligamentum hepatogastrica and hepatoduodenale, they both form the lesser omentum. What is a lesser omentum? Two layers of peritoneum are folded together. Inside is much fatty tissue, lymphoid nodes, lymphatic nodes, and then vessels. And this altogether is called lesser omentum. Liver is covered by peritoneum on 3 sides. Just small portion, bare portion, is called area nuda. It's not covered, but all the rest are covered by peritoneum. So liver is mesoperitoneal organ. On the visceral surface of a liver, you can see the groove herein for gall bladder called fossa vesica fele. Liver structure. So I said to you that the liver has 2 lobes, right and left. It's the posterior view to liver. This is right and this is left. And on the visceral surface, you can see 2 more lobes are added. So the right in turn is divided into 2 more. It separates 2 more. Quadrate and caudate liver, a lobe. So we can say that liver has 4 in general. Right, left, quadrate, caudate. Then liver is divided into sectors, segments, and lobules. They are numbered They have names in Latin. You should know them for practical classes and for exams. As I said, the main function of liver is detoxification of what we have eaten. So everything that you have had from the stomach and up to the upper portion of rectum is absorbed to the branches of mesenteric and mesocolic veins, and they are collected into hepatic portal vein. Here it is, hepatic portal vein. So what vessel is bringing these substances to liver? Hepatic portal vein. And these all substances are to be detoxified there. But these are nutrients, and the oxygen is brought by hepatic artery, which is the branch of celiac trunk coming from the abdominal aorta. So two vessels are coming into liver, and what is exiting from liver? Purified nutrients inside the hepatic veins. Also, liver is producing bile. That's why the bile ducts, right and left, are also coming out of liver port. Everything that is coming inside liver is mixing up, processing inside the lobes, segments, and then lobules. And these are how hepatic lobules looks like. You can see in the angles they have the branches of hepatic portal vein bringing nutrients for detoxification, and hepatic artery bringing oxygen for this process and for liver needs. While coming to the center, they are processing the blood, and while the nutrients here are purified, they are collected into central vein, which is in the center of each hepatic lobule. Central vein. At the same time, production of bile is accomplished in the opposite direction, so from the center towards the periphery, and is collected into the smallest bile duct, which is called ductulus biliferi, located in the angle of each hepatic lobule. Here how it looks like. And actually, we distinguish three types of morphofunctional unit of liver. Classic lobule, hepatic lobule, is hexagonal shaped part of liver parenchyma, which is having central vein in the center and hepatic triads in angles. What is hepatic triad? This is part of hepatic, a branch of hepatic artery and branch of hepatic portal vein. The next, portal lobule. If we'll connect the central veins, we'll have the triangular part of liver parenchyma with the triads in the center and central veins in angle. And liver acinus is in between the central veins with the triads in the dull angles. So all of them, all these three, are responsible for different functions. Classic lobule is purification of blood. Portal lobule is the production of bile, and acinus is all together. So three morphofunctional units of liver should be named by you on exam. These are the image of hepatocytes. Now gall bladder. After liver produce bile, it will be connected by smallest ducts at the angles of hepatocytes called ductuli biliferi They will be joined to form ductus interlobularis, then ductus intersegmentalis, and then ductus hepaticus dexter and sinister from two great lobes of liver. They will be joining to form ductus hepaticus communis, common hepatic duct, and for temporary storage it will go through cystic duct to Gall Bladder, located in fossa vesica-phellia. Vesica-phellia is a Greek name for Gall Bladder. Here will be temporary storage, and when we eat something and need bile for splitting of fat and fat-soluble substances in the descending portion of duodenum, here it is, it will go out then by reflex to ductus holidocus and come into the ampulla holidocho-pancreatica. So it's joined from holidocus and pancreatic gland. Here how it looks like. The less we eat, the less bile comes out from its place of temporary storage from gallbladder to duodenum. And in this case, the bile will be very aggressive, very alkaline, very concentrated, dark green color. If we eat by small portions, it will be less concentrated, it will be light yellowish. So this is how bile collection is accomplished. From the smallest ones and then to greater and greater, and will come out to the right and left ducts. And here how we can see the radiography of biliary ducts. It's very interesting because sometimes we can see even gallbladder stones inside. On the way there are several sphincters. And you should make photo of this slide because they are not named in all the textbooks. Sometimes they are missing. But you need that for exam. So number 2 is sphincter of Lütgens. Number 3 is sphincter of cystic duct. Number 4 is vesica-phellia. It has the sphincter just here. And then it will have the sphincter Oddi already inside the wall of the duodenum. The next large gland is pancreas. The head of pancreas is located in the loop of duodenum. The body of the pancreas is located behind the stomach, and the tail of pancreas is just getting in contact or touching the spleen. It's a large mixed gland which has endocrine gland and exocrine part and endocrine part, and its main duct divides into two. Main duct goes out to the papilla major of duodenum. Accessory duct goes upwards to papilla minor of duodenum. So here how it looks like exocrine and endocrine parts of pancreas. Exocrine portion of pancreas is responsible for production of pancreatic juice, which is joining with the bile in the ampulla holidocho-pancreatica and exit to the duodenum. Endocrine portion is represented by Langerhans islets and has PP cells, D cells, B cells, and A cells. Sometimes they are called by Greek letters, so alpha, beta, delta, and PP. Also, some scientists mentioned theta cells. So, alpha cells are responsible for production of glucagon. Beta cells are responsible for production of insulin. Delta cells are responsible for production of somatostatin, and PP cells produce vasoactive intestinal polypeptide. Now, anomalies, I will just say it in brief because we have not too much time to study. Moreover, during your second year, we'll pay more attention to anomalies formation. So it is just plan how anomalies are classified and how they are called. Because of the different structure, they may be quite different, and you will saw them later. Here I will want to show you the different lesions or deviations from food consumption, from the functioning of the digestive tract. So these are obese person, and anorexic person. And hypotrophy is the deficiency of body weight because of poor digestion. And the last thing which I have to mention today is peritoneum. Peritoneum is a serous coating inside the abdominal cavity. Actually, we have three serous coatings in thoracic cavity. They are plurals for lungs and one isolated for pericardium. In abdominal cavity, the serous coating is called peritoneum, and actually it's a semi-transparent sac enveloping the organs, and all that is a visceral layer of peritoneum. And parietal layer of peritoneum is just adjacent or close to internal abdominal wall. This is how this peritoneal sac is forming. So firstly it's entire, then the body organs, the buds of the organs are appearing on this peritoneum, and while developing these organs, they appear to be enveloped from all the sides, or from one side, or from two or three sides, and according to that we name the organs and their coverage by peritoneum, like from three sides or from all sides. When it's covered, when the organ is covered from all the sides, we say to it intraperitoneal coverage. From two or three sides, mesoperitoneal coverage. From one side, extraperitoneal coverage. But some organs are appearing behind, they appear behind the peritoneal sac, and we name them retroperitoneal. The examples of retroperitoneal organs are like aorta, kidneys, urethra, thoracic duct. And here you can see the sagittal of the lining, how peritoneum and its visceral layer are lining all the organs. So visceral layer of peritoneum, it produces some fluid, and parietal, adjacent to internal abdominal wall, is consumpting this small amount of fluid. This small portion of fluid prevents friction while moving of loops of intestine. And if we have the inflammation and we have excess of peritoneal fluid, this will call pathology called ascites. Visceral peritoneum, it may suspend from one organ to another. If it comes from one organ to another, let's say from liver to stomach, it is causing the formation of ligaments like hepatogastric ligament or hepatoduodenal ligament. And also it can suspend, as you can see here, like an apron from the greater stomach of a greater curvature of stomach to the large intestine, exactly transverse colon. So here it is called the greater omentum. Why omentum, which from Greek means something fatty or fat? Because inside these four folds, four lines, four sheets of peritoneum, inside is much fat, then lymphatic nodes, some vessels sometimes, and it helps to protect inner organs. If the person eats much, this fatty apron that is called greater omentum, it also increases in volume and creates large belly. The ligaments in between the liver and stomach causing lesser omentum, they're here, and greater omentum just front to intestinal loops. Also, peritoneum can suspend the loops of intestine to posterior abdominal wall, like here, and this is called mesocolicum. And mesentery is the portion of peritoneum suspending the loops of small intestine to posterior abdominal wall. So that is called mesentery. Attaching the loops of intestine to posterior abdominal wall, peritoneum gets down, covers the upper portion of rectum from all the sides and middle portion of rectum just from one side, from one side, and then in between rectum and uterus in female, it makes up a pouch that is called Douglas space or posterior pouch, so recto-uterine pouch. And in between the uterus and urinary bladder, it will make up one more pouch. It will be called vesico-uterine pouch. Here it is male's torus, male sagittal, so the pouch is only one, rectovesical. In female, here in between there is the uterus, and there are two pouches, anterior and posterior. Posterior is called Douglas space. Here is the greater omentum, how it looks like from the front. And this is the female's sagittal with the posterior pouch or Douglas space and the anterior pouch or vesico-uterine pouch. This has a great diagnostic meaning. If the surgeon is suspecting blood in abdominal cavity, it can make through vagina the puncture to the peritoneal cavity, appear in the posterior Douglas space, and the pulling of the syringe will show is there any foreign fluid in the peritoneal cavity or not. If we look onto the anterior abdominal wall from the inside, we'll see the folds that are caused by peritoneum on the anterior abdominal wall from the inside. These are median umbilical fold called plica umbilicalis mediana. Then lateral umbilical folds, here lateral, and in between are medial, so median, plica umbilicalis mediana, plica umbilicalis medialis, and lateralis. Of these 5 folds, only lateral ones are having the acting vessels inside. The arteries are inside, which are passing the blood in adults, the epigastrium. But inside the median umbilical fold, there is the former embryonic duct called urachus, which connected in embryonic period the urinary bladder with the allantois. And in the medial umbilical folds, there were former umbilical arteries that were functioning only in embryonic period. I said you already that peritoneum is suspending the horizontal portion of large intestine that is called transverse colon. Here is the cut mesocolon. And also it suspends in oblique way, in oblique mode, the loops of small intestine, and it's called mesentery. So this is the cut oblique root of mesentery. As you can see here, it forms two pouches, the right mesenteric pouch and the left mesenteric pouch. It's helpful for surgeons to understand where they should make a revision of the perforated ulcers or perforated intestinal walls. And also, despite a part of these sinuses, there are the connections and pits between these folds of peritoneum. They are called bursas, they are called recesses, they are called folds. And if we will be talking about bursas, behind stomach there is the so-called omental bursa, because it is behind less omentum and behind stomach. Only small foramen, which is called foramen epiploicum herein, leads to omental bursa. Why it is necessary to know? Because if there is a perforated ulcer of posterior wall of stomach, you will not see it on the anterior surface. No, instead you should check if the posterior, this bursa or bursa omentalis, is free of the stomach content. Through this epiploic foramen, the omental bursa is connected to the hepatic bursa. It's also like a sort of space corresponding to the right lobe of liver. And in front of stomach, one more, which is called pregastric bursa. Pregastric bursa. And they are blind-ended. Here is the transverse section, which shows that omental bursa, herein, omental bursa, through epiploic foramen, is connected to hepatic bursa. Epiploic is connected to hepatic bursa. Then right paracolic gutta is the continuation to hepatic bursa, and that shows where the surgeon should check the content in case of catastrophe of the abdominal cavity. The pregastric bursa is blind-ended. The right mesenteric sinus is also blind-ended. Left mesenteric sinus has the connection to pelvic cavity, as you can see here. Small space is opened in the pelvic cavity from the left, but actually the left paracolic gutta is blind-ended, because on both sides there are ligaments that makes it blind-ended. This is the revision of the omental bursa by surgeon. That's it for today. Hope you understand the major parts. Hope that was not too difficult for you. But anyway, you can look it through once again. Make some notes in your copybooks. Good luck.